Randy Brown, want to thank you all for a little time this morning to talk about my program of research in the Department of Family Medicine and Community Health. This format is a little unusual for those not familiar with Pecha Kucha. This is a very brief presentation, 20 slides, about 20 seconds apiece, utilizing imagery to try to convey the sort of work that we're doing on our team. The idea with this and other such presentations is to enhance an understanding throughout the department of the research that's occurring, and perhaps to also encourage reflection on practices and policies that affect the health of our patients and the communities in which they live. So my work focuses particularly on alcohol and other substance use and related complications, including but not limited to addiction. And I really focus most of my work on settings outside of specialist treatment. Given prevalence rates around risky and problem substance use in the United States, which exceed 30% over the lifetime, specialist treatment agencies are not treating us out of where we are. It is incumbent on many facets of society, including primary care and other general medical settings, to tackle some of these issues. So, to take a step back by way of an introduction to some of what we do and why we do it, I would offer that the seeking of altered states of consciousness has been around for tens of thousands of years, and likely more. Anthropologists and ethnobotanists have argued that that drive is one every bit as primal and potent as those associated with thirst, hunger, and sexual desire. That can take many forms, these altered states of consciousness, and can include spiritual and meditative practices or extreme physical exertion. However, mind-altering substances have also been a part of this equation for, as I say, tens of thousands of years, and likely more, because we know that species lower on the evolutionary ladder than ourselves not only achieve intoxication in the wild, but actively seek it out. Primary examples involve the use of fermented sugars found in the wild in fruits and other things. Another interesting example in Siberia, reindeer are quite common, so is psilocybin, or magic mushrooms, and they've been known to actively seek out that experience. Interestingly, there is also stigma attached to intoxication in some species. Honeybees, for example, will expel intoxicated members from their colony until they can return in a more sober state of mind. So, substance use has been with us for a long, long time. New substances are coming out all the time now, right? Synthetics and the like. It's probably not going anywhere anytime soon. In the vast majority of instances of substance use, there aren't any discernible adverse consequences, right? However, these things do happen often, and they happen often enough that issues associated with substance use cost the United States more annually than all forms of cancer combined when we account for lost productivity and court costs, for example. A lot of what has come before in terms of prevention and practice when it comes to treatment hasn't served us particularly well, in part because it hasn't been soundly based in science or even common sense from time to time. With that in mind, and given just by definition the multidisciplinary nature of the approach that needs to be taken in this area, our work involves collaboration with a number of departments here and at other institutions, such as social work, psychology, criminology, pharmacy, and industrial engineering, where we engage in efforts around prevention as well as treatment. Again, in settings outside of specialist treatment, because again, upstream prevention is quite important in this area. So to give you a few examples of particular work, in one study, we were given that alcohol use disorders pretty frequently lead to hospitalization at some point during the life course. We were interested in looking at the impact of starting appropriate pharmacotherapy while alcohol-dependent veterans were hospitalized, not waiting for that outpatient follow-up, but getting naltrexone going in either oral or injectable form before they leave. And surprisingly, even to myself, we achieved treatment engagement rates and consumption rates for alcohol approaching 90% after 6 weeks of follow-up after those interventions on the inpatient setting. We also do a lot of work with diversion programs in the community, seeking solutions other than incarceration for the treatable illness of substance use disorders. So we collaborate extensively with the Drug Treatment Court and the Drunk Driving Courts in Dane County to evaluate services that might be more effective in reintegrating these populations. We also do a lot of work looking at the potential effectiveness of mobile technology to facilitate recovery, and we've achieved some significant results for individuals coming out of specialist residential treatment facilities with this technology that can provide support in terms of cognitive behavioral therapeutic education, connection to discussion boards, and the development of a community that can support them, in addition to a number of other features. We also, I'm excited to report, recently received a several $1 million NIH grant to leverage this technology to get out into rural areas in Wisconsin and intervene with rural injection drug users to try to get them tied into, sorry, this stuff gets me sometimes. Get them tied into Hep C testing and treatment, and get them into the treatment that they need. This one. I collaborate with the Department of Kinesiology to see about integrating protocolized exercise regimens into behavioral treatment, and we've had some exciting early results around fostering well-being for addicted individuals in those programs. And speaking of prevention, we can't escape in the news issues around the opioid crisis. Much of that impact is due to prescription opioids. And so it's incumbent on us as prescribers to be actively thinking about these practices. The available guidelines are quite cumbersome and difficult to implement. So work that we're doing intervening at clinic and system levels is seeking to facilitate improved adoption of some of these guidelines and monitoring in primary care settings. I'm also interested in expanding treatment for opioid use disorders into more general medical settings, such as primary care, general psychiatry. So we're involved in a project intervening with payers and health systems in Massachusetts, Ohio, Florida, and Wisconsin, seeking to develop feasible ways to expand this treatment option. We're doing a study right now at University of Wisconsin Hospital. The population of individuals who experience a traumatic injury represent a population at particular risk for developing difficulties with opioid misuse or even eventual addiction. So what we're working on is developing and validating a brief screen that might be helpful in terms of assessing a risk level that might guide monitoring practices or the delivery of early brief intervention to prevent misuse or prevent misuse episodes from progressing to addiction. We also work extensively with outreach programs, such as Wisconsin's Mobile Needle Exchange, to provide education around overdose prevention and education. Given that legislation making lay possession of naloxone legal was fairly recent, we're doing surveys of injection users around the state to get a sense of sort of knowledge, behaviors, and attitudes around interventions at the scene of opioid overdose, and to what extent they're calling emergency medical services and the like. In a more perhaps unconventional line of work on which we collaborate with investigators at Johns Hopkins, NYU, and the University of Alabama, there's gotten to be renewed interest in the therapeutic potential of other mind-altering substances, such as psilocybin, as a primary example, which under supervised conditions by a mental health professional in a closed environment has really resulted in some impressive findings, even up to a year out from that experience, around aspects of personality involving openness, empathy, and a sense of belonging that's had therapeutic effect for anxiety in the setting of terminal cancer, social anxiety associated with autism, and we're particularly interested in application for substance use issues. In a study at Johns Hopkins, they achieved particularly impressive results for tobacco use disorder, where in a sample of individuals who had failed treatment, traditional treatment, an average of 6 times, they had quit rates 1 year out from an individual supervised psilocybin experience of 80%. That's almost double what we get with currently FDA-approved therapies. So what we're interested in now is extending the potential application of supervised administration and behavioral therapy to opioid use disorders and seeing to what extent that might facilitate improved rates of recovery. Another substance along these lines that's getting a lot of attention is MDMA, or ecstasy, where the primary application to date so far has been treating refractory PTSD. I'm not sure if you've seen some of those findings, but they're actually compelling enough that we are taking part in a phase 3 multi-site trial that seeks FDA approval for MDMA-facilitated psychotherapy for issues like PTSD. And eating disorders look to be another area of promise where treatment can really be a difficult set of issues. So, and that's what I have for you this morning. Sorry, I lost it for a little bit.